Today we're going to be talking about a patient who came into the ED saying he felt weak and was having bloody diarrhea. He said that, so this is a 45-year-old male with past medical history of Crohn's. He was supposedly diagnosed in 2016. He had bilateral DVTs that were about 1.5 years ago. He wasn't currently on anticoagulation when he came to the hospital. He has ADD and he presented to the ED with 2 weeks of generalized weakness and fatigue, abdominal pain, and about more than 10 episodes of bloody diarrhea recently. He mentioned that he hasn't had a bloody bowel movement though in about 2 weeks, and instead describes the bowel movements as looking like the inside of his colon and fluffy. Most of his symptoms started 6 months ago, but he is presenting now because the abdominal pain is worse and his diarrhea has been more frequent over the last 2 weeks. The patient says this feels like his previous Crohn's flares. He doesn't currently follow with a gastroenterologist and isn't on any medications for his Crohn's. The patient also mentions that he's been having increased shortness of breath with exertion. Past medical history, I mentioned the Crohn's disease, ADD. He had gonorrhea in 2015. He is only taking ibuprofen and Tylenol PRN. He says that for his abdominal pain, he's mostly been sticking with Tylenol, but has been taking the ibuprofen, takes the mucopurocin cream, not regularly, and Adderall. And he has no family history of IBD or colorectal cancer. He's being seen at the Ryan Chelsea Clinic, but mostly goes when he has acute problems. No recent physicals. He's up to date though on his vaccinations, and he had HIV testing recently in the last 6 months. Surgeries, he's only had shoulder surgery, but he's had multiple colonoscopies for the Crohn's disease. He doesn't use alcohol, tobacco products, or drugs. He's sexually active with men only, and lives alone and is independent. And he's only allergic to Cipro.
Anybody want to ask any more questions pertaining to the history or past history? Or anything about, any other questions about his presentation, about how the diarrhea was, when it started? If not, we can go ahead.
Okay. In his review of systems, he mentioned a 27-pound weight loss in the last 6 months. He mentioned the fatigue, but denies any fevers or chills. He's been having dyspnea on exertion, but no wheezes or coughing. And he has been having this abdominal pain that's very severe, and one of the reasons that brought him in. And he's had blood in his stool and diarrhea as well. He mentioned some dysphagia when we asked about it. He has a purplish rash on his legs bilaterally, mostly in his ankles. And then he also complains of some lightheadedness that he attributes to having a lot of diarrhea and some mild headaches that he's been having on and off.
All right, let's move forward to the exam.
The exam, or you want to do the, oh yeah, okay, physical exam, sorry. Vitals, he was tachycardic to 127. Otherwise, the rest of his vitals were within normal limits. I didn't have a baseline weight on him, but he was now 127 pounds. So he had mentioned losing about 27 pounds. He was anxious and clearly in discomfort holding his abdomen. Otherwise, he was tachycardic as well. And there was abdominal tenderness that was diffuse in nature, but mostly also at the left lower quadrant was the most severe. On his rectal exam, there was no occult blood and no stool though, so that we weren't really able to appreciate if there was any blood in the stool at that time. And then his skin exam was significant for these bilacious plaques on bilateral lower extremities. And in terms of, so this is what the rashes looked like. Some of them were raised, but this is what the majority of them looked like.
Anybody want to take a stab and describe the rash? I mean, we already have some descriptors, but any words which or descriptors which come to mind? So, who's going to help us? So, Lenise, you want to?
Anybody.
Lenise, can you describe, what do you think? I mean, but none of us is a dermatologist. What does this rash look like?
This rash doesn't have well-defined borders.
Okay, what color is it?
Biolaceous rash.
Biolaceous or purple?
Rash,
Keep it
yes.
simple, yeah, purple. Can you see? I mean, is it a patch? Is it a nodule? Is it a plaque? What does it appear?
It looks like patches, but not that much.
Okay. It's hard to see because it's not three-dimensional, but it looks like small nodules, right?
Yeah, it looks like a small nodules, but also some of them are not raised.
Yeah.
So it's very mixed.
Okay.
Lesions.
Purplish, violaceous, nodular,
Yeah.
and then some plaques. Does that sound fair to everybody, or does anybody want to add some other descriptor? Okay, so I think that's good enough. Any other questions anybody wants to ask about the examination? Let's go back one slide. Anything else you would have elicited, or any other examination finding you would want to elicit in this patient? Nothing?
Did you mention that does the patient has HIV, or I don't remember?
No, we don't, as of now, no, because he's been tested pretty recently in the Ryan Clinic. He was tested within the last 6 months in the Ryan Clinic.
Okay, thank you.
But he still had high-risk behavior after that, right?
Yeah.
I guess you wouldn't jump straight to examining for it, but any mention of any penile discharge, bumps and bumps down below, or anything like that? Yeah,
we didn't do a penile exam because he was coming in with diarrhea mostly, but I guess for the abdominal pain, we could have. He just wasn't complaining of anything on those areas, and his UA.
That's a good point, Joe. Can you think of any unifying, any reason why he could have both?
Yeah, I was just thinking if he's got anal gonorrhea, it seems like it's been going on for a long time, so you'd expect some pus or some sort of systemic features, but just in case.
Yeah, absolutely, great point. So a lot of STIs, especially in receptive intercourse, could lead to proctitis, and that can lead to what this patient is presenting with, the bloody diarrhea. But those patients, when you have proctitis, they have some clinical features which are, which raise suspicion for proctitis. One of those is tenesmus. So if somebody is coming with tenesmus, then you have to think about proctitis, be that through an STI or through ulcerative colitis, or even Crohn's if it involves the rectum. But tenesmus is something which you should think about proctitis. All right. Any other questions before we move on to the next step? Anybody want to know what his last scope was like? That's important, right? When you have somebody who has this kind of chronic illness and has IBD, you want to know what's the disease severity, what was the extent. This is not UC, this is Crohn's. So you want to know which areas it's affecting. Crohn's, as we know, can affect any area from the mouth to the anus. So you want to know, is it a left-sided involvement, right-sided involvement, rectal involvement, terminal ileum? So that's also important. So you want to make sure that you review all the last the last colonoscopies, and especially the extent of the information on the biopsy. So the biopsy results are also important.
Yeah, for the Crohn's, at least for his last colonoscopies, it wasn't actually clear whether or not he had Crohn's. We were going through some of the pathology reports, and they weren't characteristic per se for Crohn's with crypts. It was kind of just general inflammation. But somebody at one point did tell him he had Crohn's. It didn't seem like from our search. It could have been something that was done outpatient through another gastroenterologist, but you did have 3 that were here. It did show inflammation in, I believe it was just parts of the transverse colon. It was just one part of the colon. It wasn't pancreatitis or that severe. And he had I put a few dates that he had the colonoscopies, and they're pretty close to each other. And some of the areas that were inflamed in one colonoscopy wasn't inflamed in the next. So it wasn't like long-term consistently inflamed.
And Dr. Sharma is asking, what treatment was he on for Crohn's? He wasn't on any treatment, right?
Not that we know of that he was ever put on any. He might have, at the times of flares in the past, been on steroids.
So it seems like somebody who had acute flares, came to the hospital, was treated for this acute flare with steroids, but was never been seen by a gastroenterologist or treated for, with biologicals or any other immunosuppressants. Okay, sounds good. Let's move on.
So next is the problem representation.
So who is going to help us? Tina, you're next. We'll do it together.
Okay, so this is a middle-aged man, history of Crohn's disease, DVT, and ADD, coming in with like kind of subacute fatigue, rectal bleeding, weight loss for the last 2 weeks. Or two weeks, yeah.
Yeah, so we know who the patient is. It's a middle-aged patient with past history of Crohn's, very important, who comes in with, I would say the main presenting symptoms in this is bloody diarrhea and then weight loss. So those 2 would be, the clinching or the most important presenting symptoms. Then what are your pertinent exam findings? Seem to have abdominal tenderness and seem to be tachycardic, and also do not seem to have with any blood on the rectal exam, because that means he's not currently bleeding. Mm-hmm. And I really like your descriptor. So it is subacute diarrhea. I would say when you're talking about diarrhea, you can talk about acute, subacute, and chronic. Chronic is usually more than 4 weeks. So this was, I think, around 2 weeks. So this would be, acute to subacute. So that's something else to keep in mind. And yeah, so Emily, can you show us what you came up with?
Yeah, so I came up with this 45-year-old male with past medical history of Crohn's, bilateral lower extremity DVTs, high-risk sexual behavior, presenting with chronic but progressively worsening generalized malaise, unintentional weight loss, abdominal pain, greater than 10 episodes of bloody diarrhea, and dyspnea on exertion over the past 2 weeks. Examination consistent with the tachycardia, abdominal tenderness, multiple lower extremity violaceous plaques, and no gross blood on DRE. So for this, I remember Dr. Pergolini saying that we don't necessarily, for all of the past medical histories, including the ones that are important. So I didn't think that ADAD was necessarily as important in this case. But I also tried to do the, like Angad was saying, with the chronic or the acute, differentiating, and especially in Crohn's patients and ulcerative colitis patients, you want to mention the number of bloody diarrhea episodes they have, or diarrhea episodes they have, because it differentiates whether the severity of that as well.
Great. And another point about this rash as well as diarrhea. So this is, a different rash, but what other rashes would you, possibly see in patients with Crohn's or any patient with inflammatory bowel disease? Is there any rash which is an extraintestinal manifestation of IBD?
Oh, sorry, I just totally messed this up.
So yeah, Bruno in the chat says pyoderma gangrenosum, and Jonas says erythema nodosum. These are common extraintestinal manifestations of IBD. So pyoderma is seen in a lot of patients with ulcerative colitis, It's usually seen on the lower extremities, but it's not, it's like an ulcer, right? It's not like this violaceous nodular rash. It's a large ulcer, well demarcated and usually very painful. Erythema nodosum is also, it's not violaceous, it's usually red, it's tender, paniculitis seen in the shins, and Linese also pointed out psoriasis. That's also something which is seen as, can be seen in these patients, but not as frequently as pyoderma. All right, let's move forward to the labs.
Well, do we want, I guess at this point, do we want to talk about leading diagnoses, or you want the labs first?
Or we could talk briefly about diarrhea. So this is the main presentation, right? Patient with subacute diarrhea. So what are the most common, what's the most common framework for diarrhea? Anybody has, a framework? What if a patient comes with subacute to chronic diarrhea, what are the most common, subgroups? Anything in this patient's history which makes them, in a particular subgroup? Infectious is more specific, something a little broader than infectious. Sounds like infectious. Right, inflammatory. So the most common subgroups of diarrhea, especially when you're talking about subacute to chronic diarrhea, are inflammatory and non-inflammatory. Infectious is a subgroup of inflammatory diarrhea. And Bruno, can you tell us why you think this patient has inflammatory diarrhea? Or anybody?
So the fact that the diarrhea looks bloody and he's been having multiple episodes, and that it's associated with other systemic symptoms such as the generalized malaise, the unintentional weight loss.
Absolutely. So I think the key point here is bloody diarrhea. So, and the presence of blood in your bowel movements makes it is only seen in inflammatory diarrhea. Non-inflammatory diarrhea will never have blood in it. Yeah, history of Crohn's. Yeah, that's another another thing which points towards inflammatory diarrhea. But when patients with chronic diseases come with, you have to always make sure that they don't have any other. Sometimes they can have some other cause for diarrhea. A patient with Crohn's diarrhea or Crohn's disease can come with an infectious diarrhea or some other form. So you always want to make sure that you repeat your diagnostic process without anchoring on one diagnosis. So blood is one. What are other things which would make you think about inflammatory diarrhea? Not in this patient, but in general. Any other symptoms or signs or any other tests in which you can do to differentiate between inflammatory and non-inflammatory diarrhea? Yeah, Galit says ESR. Yeah, that's any inflammatory markers. That's one, but more simple things. So more simple things in the patient's presentation. Calprotectin as well by Linese. That's something which we use in patients with IBD, but more simple. So if presence of fever, if a patient has fever, that points towards inflammatory diarrhea and not that's only seen in inflammatory diarrhea. We talked about blood. Pus, if the patient's bowel movements are accompanied by pussy material, that's also seen only in inflammatory diarrhea. And then on testing, apart from these inflammatory markers, if you see WBCs, fecal WBCs, that points towards inflammatory diarrhea, and that should point towards workup for inflammatory diarrhea. So let's talk a little bit about non-inflammatory diarrhea. Anybody know the two most common subgroups within non-inflammatory diarrhea? Or any examples? Good, Bruno. Osmotic. Yeah, that's one subgroup. And what's the other one? Good. Yeah, Joe got it. Secretory diarrhea and then osmotic. And the way you differentiate between the two is a stool osmotic gap. A stool osmotic gap is high in osmotic diarrhea and low in secretory diarrhea. Don't really need to go into a lot of details for now, but the most common examples of secretory diarrhea are usually medication related or bile acid diarrhea, bile salt diarrhea, or VIPomas and all of those other neurohormonal tumors. And then osmotic diarrhea can be dietary, you're taking some medications or you're taking excessive dietary, if you're on laxative, sometimes we don't do a good medication history. Patients are on, osmotic laxatives, and that leads to osmotic diarrhea. So let's talk about inflammatory diarrhea now. So what are the most common causes of inflammatory diarrhea? Let's exclude IBD because that's very obvious in this case. Like this IBD is one cause of inflammatory diarrhea. Any other causes? Anything else? I think Nobel pointed to one earlier, infectious. Yeah. Let's talk about infections now. Which infections can cause bloody diarrhea or inflammatory diarrhea? Let's just divide it into the categories. Bacteria, any common bacteria? Bloody diarrhea causing bacteria. E. coli, Shigella, Salmonella, all of these are correct. EHEC. C. diff is another one. And then let's talk about chronic diarrhea. So in a patient who is, just recently incarcerated, comes with bloody diarrhea, possibly is not from the US, wasn't born here. The other cause for chronic diarrhea, which is bloody, is you have to rule out TB, correct? So now moving on from bacteria to parasitic. What parasites can cause bloody diarrhea? Then he said Giardia. Giardia usually causes watery diarrhea. What are the most common causes of bloody diarrhea? Yeah, Jonas says amoebiasis. So entamoeba is a very common cause of bloody diarrhea, causes colitis, and is a very common mimic of IBD, especially in developing countries. Any other causes of? Let's move on to viral. What are the viral causes of bloody diarrhea? A patient who might be immunosuppressed, the patient has IBD, has had multiple courses of steroids. CMV, that's a good one. CMV colitis causes bloody diarrhea and is a very common mimic. Anything which usually always goes along with CMV? CMV and that virus go together. They usually cause similar manifestations in different parts of the body. HSV. So CMV colitis and HSV colitis usually go together. The way you diagnose these is by biopsy. You do a colonoscopy and you have to do a biopsy to diagnose these. And there's no stool tests. There's no PCR which can diagnose these. All right, moving on from infectious to others. So we've talked about infectious, talked about IBD. Any other cause of inflammatory diarrhea? Let's just talk about the three left. Microscopic colitis. So that I would say microscopic colitis comes under inflammatory bowel disease. So that would be IBD. It's a less common type of IBD, but still IBD. Any other major groups?
So the hint is the patients you see on 9A and 9B.
Yeah, patients at Mount Sinai West, some patients also at Sloan.
Major group, weight loss, bloody diarrhea, abdominal pain.
Yeah, cancer patients. So cancer patients can present with bloody diarrhea as their presentation of the malignancy. So that can be colon cancer or lymphomas. But sometimes the treatments we give them can also cause bloody diarrhea, right? Any cancer treatment which is notorious to cause inflammatory diarrhea? It can cause inflammation anywhere in the body. Major group of cancer medication which leads to inflammation in a lot of organs. So immunotherapy related colitis can cause bloody diarrhea, and it's usually a very difficult thing to differentiate from a lot of other causes of inflammatory diarrhea, which also requires colonoscopy and a biopsy. And it has its own treatment, right? This treatment can sometimes, just limit to stopping the offending agent, but sometimes it can also need immunosuppression. And that has its own, classification, staging, and severity index. So that's for another day. So that's okay. So we talked about IBD, infectious, immunotherapy related, and then malignancy. Anything else? Anybody wants to talk about inflammatory diarrhea? Any other common cause of, or any other cause of inflammatory diarrhea? I think that's about it from my end. So we think this patient has subacute to chronic diarrhea. In this particular patient, what do you think are the possibilities? IBD, of course. Infectious, we also said. Any other type of diarrhea possible? This patient has a rash. Anything else which you think could present with a rash, as well as Nobel says Kaposi sarcoma of the GIT? Yes, this patient has some risk factors, also has this rash on his lower leg. Then he says HIV. That's one possibility. So what would you think of can cause diarrhea in this or colitis in this patient with HIV, apart from the KS? The patient can have KS of the skin, but can also have AIDS, so that can have infectious diarrhea, right? So you have to always rule out infectious CMV and bacterial causes of diarrhea. All right, so we have a framework. Let's move ahead and see what this patient ended up having.
Yeah, so just like before we move forward, so to round this all conversation, which we had for 15 minutes. So many patients come to us with diarrhea. We already get so much of workup done, but like if you want to really, dissect them and figure out what actually, so that you can pinpoint and like walk in a direction. Here we know that this patient had Crohn's disease. Let's say we did not know that. So like Angad said, we have to classify, first of all, between like chronic and acute diarrheas. So like there is subacute classification, but if mainly you can if it is like more than 2 weeks, then it's subacute versus chronic. If it's less than 2 weeks, then you are dealing with a chronic acute diarrhea, correct? So you can differentiate it into osmotic, secretory, and inflammatory. And then inflammatory can have all these inflammatory bowel diseases. You can have like infections, and you can have like cancer. So how do you differentiate like which you are dealing with here? Because like they all are having like bloody diarrhea. They'll say, hey doc, I'm just going all day. So one question you can ask them, which can help you differentiate the inflammatory versus the other two, is the nocturnal symptoms. So if the patient says that they are having nocturnal symptoms, they're getting up and rushing to the bathroom, it is inflammatory. If it is like, if they're having symptoms only during the day, then it is most likely osmotic or secretory, because, like why they're having diarrhea in osmotic and secretory is because there is not absorption is not happening. Either they're eating something which is like creating an osmotic gradient, and then like it's getting through their system, versus there is defect in the epithelial lining, which is like not like absorbing the content in the colon so well, so it's getting out of their system. So that's one thing which can help. Here it was very clear he has a history of Crohn. This is bloody. So without any doubt in your mind, it is inflammatory. But so many patients come here with the viral diarrheas, and they will tell you with the viral diarrheas or bacterial diarrheas that they are having nocturnal symptoms as well. Then you have the other tests to like support your diagnosis. They have like in the inflammatory diarrheas, they have abdominal cramps, abdominal pain, all that, which can also help you with like the fevers to make the diagnosis. But not all infectious diarrhea is bloody. Very few of them are. Okay.
Thank you. Emily, you want to move forward?
Yeah, so in terms of his initial labs that were done, he had a BMP that was significant for mild hyponatremia in the setting that he was having diarrhea. We didn't correct his calcium, but it was hypocalcemia here, uncorrected. And then he had anemia. It was normocytic anemia. His baseline's 12, but here he's coming in with it 9.1. And he had a no acidosis or alkalosis. LFT is only mild increase in the D-billy. And then he had elevated inflammatory markers of ESR of 100 and CRP of 22. And then we have to do stool studies in anybody who's coming in with Crohn's disease or who you think might have Crohn's disease, because you want to, if you're going to start them on steroids, which is the treatment for acute Crohn's in these cases, you want to make sure that there's no infection because the steroids will make it a lot worse in this case, and you're treating something totally wrong. So here the GI-PCR and C. diff were negative, and the fecal calprotectin, another inflammatory marker in these Crohn's colitis patients, was elevated at 761. And then so a skin biopsy was done prior to him coming in and pending, and it did show markers that were consistent with Kaposi sarcoma. So the CD34 and then the HHV8. Then he did get imaging here. So he had some ground glass appearances in his lungs that were, you can kind of appreciate here. And he had thickening of the esophagus, which you can appreciate. I don't if you can see my marker. Chest x-ray that was normal, and his EKG just showed sinus tachy, no arrhythmias. And then he had an abdominal CT that was done as well that showed some luminal thickening in the ascending colon, which you can see here. And then there was mesenteric lymph nodes as well that were prominent. And he did, you can't really, I mean, you can see the spleen here, but in other cuts, you can see that it's bigger. He did have splenomegaly. So he did have HIV that was tested positive while he was here for the first time. So he's had multiple tests that were done in the Ryan Clinic before he came in, and that had all been negative. So this is new in the last 6 months. And his CD4 count was quite low at 56. His viral load was very high, about 1 million. LDH was elevated at 260.
Can we stop here? I know we spoke a lot, but can someone mention, like, can they distinguish if this is acute or chronic HIV from what was just in this slide and what Emily just mentioned? Can anyone tell me if this is acute or chronic, or can you tell?
I guess it looks acute, but I guess there's a confounder that would be the Crohn's, thinking that this is acute Crohn's, but it looks acute, like weight loss.
Well, we're focused more on the HIV. So you have a viral load that's positive and an antigen. So I guess the question more is this acute or chronic HIV? Forget the Crohn's. Like, don't mention the Crohn's. Anyone?
I guess does the CD4 count lag behind?
Wait, Emily, you're the
No, I know, but
I'm asking your colleagues. So Emily,
focus on the top line, everybody. Focus on the top line.
What are you saying, John?
I'm saying focus on the top line.
Yeah, like, can you tell me anything? Like, it's more of a teaching point. Like, is this acute or chronic? And Emily kind of gave a little bit of information already, which is what gets people all the time.
Remember, antigen, antibody, antigen, antibody.
I'm a little bit bummed and don't want answers. It's kind of like, this should be nothing.
I think it's acute because first the presentation, and second, as Emily was saying, the viral load is very high.
So viral load can be high in acute and
well, yes, you're right.
Right?
But she's going the right way.
But look at the top. Look at the top line, everyone. The top line.
What about the CD4? Because that's what I also. What about the CD4?
Is very low.
But what does that say? Does that say anything to anybody?
So I get, so Dr. A said top line antigen positive, so that would favor acute.
So is that the only, so let's say we don't even have the antigen, because back in the day, and you only have a CD4 and viral load, like, we're not told about that yet. So would you say anything about the CD4 at that moment? And can you say, is this acute or chronic?
Is it high or low, that CD4 count?
Low.
The CD4.
It's very low, right? Very
so is
low.
that going towards anything for anyone? I'm kind of saying, please say no. so anyway, so just the teaching point, yes, the antigen, now we have the 4th generation with the P24 antigen being positive within 18 to 21 days of exposure versus your viral load is also very high, but the confounder that everyone always has, oh, the CD4 is very low, this can't be acute. So my old research mentor, Dr. Susan Little, who's one of the ones that works very high on acute HIV, very clearly demonstrated like in the early 2000s that you can have a low CD4 upon presentation with acute HIV. That doesn't remove someone from saying that they're acutely infected just because their CD4 is low. It's all about your own immune system and how the HIV basically kind of takes away your CD4 count. This is that whole CD4 CD8 ratio that you hear about at times. So it's all about that person's immunity. So yes, the antigen gives it away, but I wanted just to make the teaching point that just because someone's CD4 is low does not mean that someone is not acutely infected.
Well,
you're going through the whole history, the viral load is very high, and then again, the antigen is positive. Go ahead.
The other point we've seen, though, we also used to see people who would have opportunistic infections in their early infection because their CD4 count goes this low. So you can see people present with meningitis, you can see them present, and this is probably why this guy who shouldn't have KS early in his disease state, because it has a very late stage complication of HIV, right? Not an early stage. He's probably having one of the rare people that is having such a low CD4 count in the beginning of his seroconversion that he can actually show up with an opportunistic infection that you wouldn't always expect in people. So it's not common, but it does definitely happen.
And that depends person to person, basically. So that's the teaching. It's not able, we cannot predict it.
Their own innate immunity, just kind of like how COVID, everyone's talking about everyone's response. It's the same thing with HIV. It's their own innate immunity. This is that whole nadir where you find out someone's CD4, their lowest was 2 when they were diagnosed, and then you see someone that's in the 700s when you see them at the outpatient setting versus someone else may never go above 200. So it's that own person's innate immunity. And, I was taught HIV meds will only increase your CD4 count by like 400 points. But again, it just depends on that person's immunity. The only other thing that I usually would ask, just as someone's diabetic, I want to know their A1Cs. When you report a CD4, you always want to report the percentage because that's going to be more reflective of the CD4 count than the actual total count. So I'm guessing this one was probably like 1%. I don't know. It might be higher actually. But that's the only other thing is like when you have a CD4 count, always give the percent, but that's for like everybody else to know. But that's it, because the time.
Thank you so much. I probably would have gotten that trick question totally. I mean, not the trick question. I would have gotten that wrong. I was in the middle of saying that I thought that they were related. So
don't say that. I thought you were doing good. Okay, never mind. Go ahead, Emily. I think y'all passed there.
So he got an endoscopy. There's a bunch of gruesome images that are coming up. But so he got an endoscopy and colonoscopy because in his case, you don't normally do it in patients. You don't have to do endoscopies and colonoscopies in patients that you're suspecting Crohn's with a Crohn's flare. It's not in the guidelines. You can just start treating them with steroids. But in his case, because he had acute HIV, he did develop SIRS criteria, or he met SIRS criteria midway through the hospital stay, or actually like a couple of days into the hospital stay. The gastroenterology team did not feel comfortable, rightfully so, in giving him steroids. So they did the endoscopy colonoscopy and found these, which are very, very characteristics of Kaposi sarcoma within the colon, within the GI tract. So on the left side, you'd see this. This is all throughout the esophagus. And then on the right side is throughout his colon. So there was like 50 plus of these, and they ranged in size. And when we did biopsies, it's also hard to do biopsies on these because they bleed very easily. So you don't want to biopsy multiple spots, but we biopsied one of them in the terminal ileum, and it did come back with the same markers that are positive for Kaposi sarcoma. So additionally, besides the point, he did have multiple other opportunistic infections. I guess not besides the point. It's just an added fact that they didn't just stop at looking for the Kaposi sarcoma. He met SIRS criteria. He had this new HIV, or at this point you're calling it AIDS. And then he also had this dyspnea. So the infectious disease team led the group in suggesting various tests and found that he did have cryptococcus. And they were concerned that he might have cryptococcus meningitis because he was complaining of headaches at one point, and he had a very high titer as well. So they suggested an LP, but the LP was normal. And it's, in his case, again, it's something that's really abnormal that he had such a high titer and didn't have the meningitis that went along with it. And then there was concerns that he had PCP and MAI. I can say some of his studies were high, but he wasn't able to produce sputum. So it wasn't able to say for sure whether or not it was PCP. And they didn't do a bronch on him to get sputum in that way. But the patient was started on atovaquone and fluconazole. And then, so when we're calling, now that this patient has Kaposi sarcoma, and we confirmed it, visceral Kaposi sarcoma treatment is different. So we'll talk about that in future slides, but he was treated with paclitaxel. And this was done instead of the doxorubicin because he had some issues that were found on TTE that made him not a candidate for doxorubicin. And then regarding starting, so in patients that do have Kaposi sarcoma, one of the biggest things that you want to do for treatment before you, in combination with the chemotherapy, the thing that's going to actually treat it is starting ART therapy. But in him, somebody who had really low CD4 count and very clearly a lot of opportunistic infections, he was at very high risk of iris. So they wanted to treat him with the chemotherapies first, and then we're going to start him on the Biktarvy.
Just one point to add here: any particular opportunistic infection which puts him at higher risk for iris? Anybody want to take a stab at it?
Cryptococcus.
Exactly. So CNS infections put you at higher risk for iris. Not every opportunistic infection puts you at high risk for iris, but CNS infections, especially cryptococcal meningitis, substantially increase your risk for iris.
And TB.
Yeah.
I was just saying the original studies were always less than C4 less than 50 puts you at high risk, especially for cryptococcal meningitis. And just another point, the reason they didn't do a bronch is we were concerned that there was lesions in the lung and just bleeding. Unfortunately, this case was discussed, I think, in 3 case conferences, and IDEA was multiple conversations with multiple attendings about what to do with him. So yes, that's the reason that we were concerned about asking for a bronch, was more for bleeding and concern for KS in the lungs.
So Dr. Soyo, can I ask, was there some discussion about, the importance of starting heart therapy early on, especially in someone who's seroconverting, to try and prevent, this, and how they weighed that with the risk of iris? Because everyone who acutely seroconverts goes through a little bit of iris as part of their normal seroconversion.
I think there was a lot of different conversations, but I think one of the challenges is they didn't want to say anything, but the patient was also someone that you had to negotiate with and what can be done. And so it's a compromise of what procedures can be done, when they can be done, what was going to be at what point. And I think everyone kind of agreed, let's at least start the therapy for the KS, and then we can start slowly, start the ART, but everyone wanted to start it early as possible, but it was just more of trying to negotiate with the patient as well.
Guys, if you started him early on heart therapy, you could actually potentially stop him from ever seroconverting. So he would be someone that would never get an HIV antibody because you intervened early. And you have to be careful with those people, right? Because they get lost to follow-up. They don't have a positive HIV test because you intervened early, but they actually are HIV positive or infected.
So everyone understands that, right? Because he was antigen positive. And if you start meds right away, you're allowing that, you know, the virus, basically, like the antibody response never to occur. So those people can be tested like 4 weeks later, 6 weeks later. And if they just get an antibody test, that's going to be negative. So our antigen antibody even test would be negative because they never seroconverted. So it's just something to kind of take in mind. It doesn't mean that all of a sudden you cure the HIV or anything like that. It just means that unfortunately, well, not fortunately, unfortunately, their immune responses was there. And so their antibody response was not there and it became negative. But you always want to start integrase and PI-based regimen for early start to kind of help with that like basically HIV inflammation. So that's why Biktarvy is a good one because it's a single pill and it's an integrase-based medication. But PIs are also good.
And in those cases, question, they're still at really high risk of transmitting it. It's not that.
Well, transmission is based on viral load, right? Yeah. So as long as the viremia is there, you can convert. Now there is a thing called U equals U, which is undetectable, is untransmittable. And that's why we're trying to kind of like really crush that virus down. So all the reservoirs are not saturated with archive virus and you really are untransmitted. You're not able to transmit if you're undetectable in the blood. That was a controversy early on, but now if we start meds right away, we can definitely say if you're undetectable in the blood, you're going to be untransmittable. So that's U equals U, and that's really helped a lot with stigma because my patients even will say like, I don't feel dirty anymore just because of this U equals U campaign that actually Dimitri Delaskis, which I can never pronounce his name because I always call him Dimitri, who's over at the CDC HIV director. He was one of the first people who brought that up, U equals U. So untransmittable, undetectable equals untransmittable.
Okay. Thank you. And then in this patient, so just as some follow-up, I looked at his chart recently and it did show, so he's been receiving the outpatient paclitaxel. He seems to be following up, although he was a very difficult patient while he was in service. He seems to be following up with most, if not all, of his outpatient doctors. And it looks like his KS has resolved in his esophagus and colon. I didn't take a look to see about his lungs, but it looks like his HIV is also doing significantly better. So overall the picture, and this is from September to March. So it's pretty relatively short time. And
where did he end up following?
Oh, I don't.
Oh, don't worry.
I don't know. I have too many patients. So just to go over some things about Kaposi sarcoma. So it's a vascular tumor, requires infection with HHV8. So that's why whenever we do the biopsies, you're always testing for HHV8. And it has periods where it's latent and then periods where it's lytic. And lytic periods are oftentimes when you're seeing the rashes and as well any other clinical effects of it. And there's kind of a debate whether or not it's transmitted sexually versus in saliva. Most of the literature does say it's saliva, but I guess early research did show patients who were sexually active or men who have sex with men, that was also a way, but it's mostly saliva. And then other patients could also be on steroids, which can lead, so when in the latent phases, it can lead to induction as well as exacerbation. So in a patient like this who had Crohn's and then had Kaposi sarcoma on the leg, starting steroids could have been pretty detrimental to him. But if we had not known that he already had visceral Kaposi sarcoma. So there's a few different types or categories. It's classic, endemic, which it was shown in patients from the African region who didn't have HIV and AIDS from before the endemic or pandemic. And then it was iatrogenic, like I mentioned, with the steroids or other immunosuppressive, and AIDS is what we're going to be focusing on. And it differs in terms of whether or not it'll be cutaneous or visceral involvement. And children can also be affected in certain situations, like the endemic version. But like I said, we'll talk about mostly AIDS. Most of it can apply to both, but here we see mostly AIDS. So since the induction of ART, the number of patients with AIDS-related Kaposi sarcoma has decreased significantly from 22,000 to about 2,000. And like Dr. Andrelli was saying, it is usually a late sequelae. So when we're starting patients on our therapy early on, you're kind of suppressing most of the patients that do get KS later on. But the patients that do have AIDS are significantly at higher risk than just the general population to get Kaposi sarcoma. And like in our patient who had a CD4 count of less than 200, he had 50. Those are the patients that are also more likely to get Kaposi sarcoma. They're about 20 times more likely to get it than patients with higher CD4 counts. And then the incidence, though, is also high, kind of like what we were saying with Iris, it will be higher in the patients that are starting it, but just during the first 6 months. And I don't think it's very high incidence of patients that do get this, though, but it's something to keep in mind. So like I said, I'm gonna have some gross pictures, and I hate feet, but in these patients, it can really present in various ways. So on my patient specifically, it had kind of these plaques that you could kind of confuse them with bruising even. And some of the areas were raised, but some of them are clearly more obvious. I mean, this is what like movies and other old pictures have mostly shown Kaposi sarcoma as looking like with these macules, but it really could be any color from like purple, dark browns, blacks, plaques, nodules, small, large, and ulcerating even. So, and I know it's also very different based off of the skin colors. So here's a patient with darker skin color. You might not appreciate that there's even a rash in this figure, but looking closer, it's important to recognize. And then I know from like steps, the differentiating between bacillary angiomatosis, the Bartonella is also important. But I mean, this does a good picture of it, but this is why you have to biopsy it, because it won't always be as clear, since Kaposi sarcoma really shows up in a variety of ways in the skin. And so it can come in the oral cavity. So all these patients, again, it looks very different from these two photos. So you want to make sure you're doing a good exam in anybody who does have any cutaneous lesions. It can cause, like if there's a trauma in the area, so this is obviously close to the teeth, that could bleed significantly. It could add another infection as well on top of it. And then in the GI tract, we saw some pictures from my patient specifically, but these are pretty characteristic of what Kaposi sarcoma would look like. And
this patient also complained of dysphagia too, right?
Yeah, the patient, dysphagia. So that's one of the other reasons that initially led us to thinking that there might be we were originally thinking CMV and HSV in this patient. And that's why we did the endoscopy and added the colonoscopy later on. So some patients can be asymptomatic, and then other patients can present like ours did. He kind of presented with all of the findings except for nausea and vomiting. And really it can show up in any part like we had in our patient. And then it can happen in the respiratory system. So like Dr. O was saying, they didn't do a bronchoscopy in this patient because it can cause bleeding with any trauma. So, but these are images of patients that have in the past gotten the bronchs done. And you can see, I mean, this image looks like there's a significant amount of bleeding. So I totally understand that this was rightfully so not done. But the problem with, so CT scans and x-rays, I mean, these kind of look like they're pretty non-specific for Kaposi sarcomas. They can show up as pleural effusions, some lesions. And if you went in and wanted to biopsy this, it could be a huge bleeding risk. There's a few other diseases that come along with Kaposi sarcoma that if it's really high inflammatory markers, you'll see lymphadenopathy in these patients and like a whole inflammatory effects as well. and these are treated, I mean, very much the same. I'm not honestly sure how you would differentiate this from anything else that was going on. But you would do biopsies and specific markers for one or the other would differentiate it. And then, so for pathology, all these patients, you want to make sure you're getting biopsies and looking for HHV8 and CD34. You'll see spindle cells, spindle-shaped cells. You'll see them in here. And then you'll see, again, the HHV8 and the CD4. And they're characteristic. You'll go from angiogenesis to inflammation and proliferation, all within the same imaging as well. And then treatment. So treatment, like I said, is mostly with art. And then what you would want to do is either think about local treatment. This is really for patients that have cutaneous Kaposi sarcoma. And then systemic treatment is patients that have Kaposi sarcoma that's cutaneous, that's pretty diffuse. So not just on the lower extremities, because the local treatment is just intralesional chemotherapies or radiation to a small area. But systemic chemotherapy, like I had mentioned before, would be either doxorubicin is the one that's preferred, but you have to get TTEs in these patients beforehand. And then, so he was on paclitaxel. Prognosis is pretty good in these patients. I believe that most of the poor prognosis comes from other age-defining illnesses or high bleeding risks or hypoxia in these patients.
Sorry, I have a question regarding treatment. Let's see, Dr. Osorio can answer this. So let's say if this patient was agreeable to starting both therapies with a high cryptococcal antigen and the LP negative, would you have started both at the same time?
I don't think so. I think that, I think that you have to, I think I would want to still do the KS and then slowly in a week, start the Biktarvy. Like, I'm not saying like a month later, maybe not even 2 weeks later, I would say like within 7 days or so, you would do both. So, but I wouldn't do like both the same day. Like there's no reason to do that, especially if someone's getting introduced to new meds. And with both, you don't want to give him a situation where like he has an adverse event and then he doesn't want to take either. So you kind of want to introduce both, but I would say within a week, the HIV meds should be started. With close monitoring, and the reason you're doing it too for him that you're comfortable is he's in the hospital and he's getting monitored as opposed to like outpatient.
So Dr. Osorio, was there any discussion of doing the reverse, starting him on ART, not treating him for the KS? Because assuming that maybe the lesions would have reverted once you kind of reconstituted his immune system?
That's a good question. I don't even know if that came up because we were just so focused on so many things coming up at once. But, I think that will be reasonable. I think it's hard because it seemed like it was very extensive for him.
Right.
I think that's the reason why everybody really wanted, especially with the bloody stools, like, his symptoms seem more from the bleeding. That I think that's why everyone was kind of like more towards starting the KS treatment, because that seemed to be what was the morbidity at that time. But again, within 7 days, really,
if you go back a decade, this would have been the treatment. We would have said, oh, let's get you on ART if your KS wasn't so severe.
Yeah.
In the hopes that it's going to go into remission and KS isn't.
That's a good point. Yeah, that's a good point. Yeah. Sorry, I won't date anyone.
We can date ourselves.
I went into HIV because patients were living longer, and I like the idea that you're a primary care physician. So that's why that's why so one of the things that was brought up is just even the diagnosis of KS and how, because we don't see it, it doesn't get caught as it should be, because people are not as familiar with the lesions and how it presents. So that was brought up, versus, a lot of the faculty were like, this was bread and butter back in the day, and everyone knew what KS was. So that was the other thing that was brought up. So I've only seen,
I think you said it was not sexual versus saliva, but we don't see KS in people that have advanced HIV from just IV drug use. We really only see it who are men who have sex with men. So that's where that whole kind of sexual versus saliva came up. But remember, when you're having close sexual contact, you're passing saliva, right? So we're seeing that with the current monkeypox outbreak, right? Close, intimate sexual contact. That's also why we saw the meningitis outbreak in Brooklyn a few years back in men who had sex with men, right? In group situations. That's how a lot of these things are passed. So it may not be exactly, you know, sexually transmitted, but you spread a lot of saliva and other droplets and stuff during sexual activity.
Yeah, I mean, so this was an M&M also. I don't know. I know that I didn't want to present it originally because of that. Well, I wanted to present it, and then I had Raul totally stole my spotlight, but I'm glad that most of the people here did not know that. But it was somebody who kind of came into the clinics multiple times, but just for not close monitoring of anything. It was a lot of very acute things. He had this Kaposi sarcoma that, I mean, it's kind of skewed a little bit here for just ease of us being able to go through diagnosing him, but he was biopsied before he even came in. And it showed as Kaposi sarcoma like a couple of weeks prior, and nobody followed up with it. And these are things that really shouldn't be missed, but I guess now that they're not as common, it's getting missed. And this just kind of goes over, you can see it in a bunch of different, it's honestly not even a great table because now I'm looking at the clinical evaluation, and these are things that you would do in a lot of patients and not just specific to here. But that's it. Thank you guys so much for participating. Glad, I didn't realize this was the last one.
Yeah, thank you everybody for joining. This was your last academic half day as interns. So we will see you on Thursdays next year. And as we had mentioned earlier, for the party next week, make sure you get a rapid within 24 hours, with the caveat that if you were positive within the last 3 months, you don't need a test. All right.
Thanks, everyone.
Thank you for joining, everybody, and have a good rest of your day.
All right, bye.
Bye.